Ladies and gentlemen, welcome to the joint session between the ESTS and JACS. My name is Ichiro Yoshino from Japan, and I'm honored to co-chair this session alongside Professor Ferenc Renyi-Bemos from Hungary. Today, we focus on a highly relevant and clinically significant topic, wedge resection versus segmentectomy in the management of small peripheral lung cancer. This session gathers leading experts to share insights and interpretations drawn from two landmark clinical trials, one conducted in Japan and the other in the United States. So we are fortunate to be joined by three exceptional speakers today. The first speaker is Dr. Tsutani from Japan. He is a professor of thoracic surgery, Kinda University, Osaka, Japan, and is a rising leader in JACS lung cancer surgery group, and will present the Japanese perspective and the latest findings from these trials. Please start, Professor Tsutani.
Thank you, Chairman, organizing committee members, and colleagues. I'm Dr. Tsutani, a thoracic surgeon from Kinda University in Japan. It's truly honored to speak here today on behalf of Japanese thoracic surgeon. In this collaborative session between ESTS and JACS, I will present the data supporting the role of segmentectomy, particularly in comparison to wedge resection for early-stage non-small cell lung cancer. I have no COI to disclose in relation to this presentation. First, I'd like to present Japanese data on sublobar resection. As you know, in Japan, the JACOG and WJOG have conducted the three major prospective trials of sublobar resection. These trials are designed based on the tumor size and the consolidation to tumor ratio. In general, GGO-dominant tumors are defined as those with a CT ratio of 0.5 or less, while solid-dominant tumors have a CT ratio greater than 0.5. We previously reported the outcome of following lobectomy, segmentectomy, and wedge resection for GGO-dominant clinical stage 1A lung adenocarcinoma. Both relapse-free survival and overall survival were excellent regardless of the surgical procedure. When we examined the pathological features, we found that lymphatic, vascular, pleural invasion, as well as lymph node metastasis were rare, regardless of the tumor size. So, GGO-dominant tumor can be considered indolent tumors. JACOG 0804 WJOG 4507L was a single-arm study evaluating sublobar resection for peripheral located GGO-dominant lung cancer that were 2 centimeters or less, with a CT ratio of 0.25 or less. Wedge resection was the standard procedure, but segmentectomy was permitted when the tumor was located deeper from the pleural surface. The primary endpoint was relapse-free survival, which reached 99.7% at 5 years. The trial clearly met its primary endpoint, confirming the safety and efficacy of sublobar resection in these indolent tumors. JACOG 1211 is another single-arm study focusing on segmentectomy for GGO-dominant tumors up to 3 centimeters in size with a CT ratio of 0.5 or less. The primary endpoint was 5-year relapse-free survival, which was excellent at 98%. The trial successfully met its primary endpoint. The overall survival, 5-year overall survival was also 98%, confirming the segmentectomy as a highly effective option in this patient group. JACOG 0802 WJG 4607L is a randomized phase 3 trial comparing segmentectomy with lobectomy for small size solid dominant peripheral non-small cell lung cancer. Eligible tumors were 2 centimeter or less in size with CT ratio greater than 0.5. The primary endpoint of the study was overall survival. As you know, overall survival was significantly better in the segmentectomy arm compared to the lobectomy arm. This trial not only demonstrated non-inferiority, but also statistically confirmed the superiority of segmentectomy. Therefore, we concluded that segmentectomy should be considered the new standard of care for small-sized peripheral solid-dominant non-small cell lung cancer. Relapse-free survival was completely equivalent between the lobectomy and segmentectomy. Therefore, from an oncological perspective, segmentectomy can be considered equivalent to lobectomy in terms of local and systemic disease control. The next topic is segmentectomy for pure solid tumors. We previously compared the outcome between pure solid tumors and mixed tumors containing a GGO component in clinical stage 1A lung adenocarcinoma. Disease-free survival was significantly worse in pure solid tumors. Even after matching the solid component size, disease-free survival remained inferior in pure solid tumors, suggesting a clear biological difference. Given their more aggressive nature, some surgeons may be hesitant to recommend segmentectomy for pure solid tumors. However, in the supplemental analysis of JACS 0802, published by Dr. Hattori in Lancet Respiratory Medicine last year, segmentectomy still demonstrated better overall survival compared to lobectomy, even for pure solid tumors. Relapse-free survival was also equivalent between the two arms. These findings suggest that segmentectomy remains oncologically valid even for more aggressive tumors, such as pure solid type. In North America, the CLGB 140-503 trial was conducted to compare lobectomy versus sublobar resection for peripheral clinical stage 1A non-small cell lung cancer with tumors 2 centimeters or less. The primary endpoint was disease-free survival. Unlike JACS 0802, this study allowed both segmentectomy and wedge resection as sublobar approaches, and intraoperative confirmation of N0 status was required prior to randomization. The trial met its primary endpoint, so sublobar resection was not inferior to lobectomy in terms of disease-free survival. Overall survival was also comparable between the two arms. In the supplementary analysis of the CLGB trial, disease-free survival, overall survival, and lung cancer-specific survival were all quite similar among the three groups, lobectomy, segmentectomy, and wedge resection. Therefore, the question now arises, when we decide on sublobar resection, should we choose segmentectomy or wedge resection? While both wedge resection and segmentectomy are classified as sublobar resections, they are fundamentally different procedures. Wedge resection is a non-anatomical, technically simpler resection. In contrast, segmentectomy is an anatomical procedure that is more complex. However, segmentectomy theoretically provides better oncologic control due to its ability to secure a wider surgical margin and allow for higher lymph node dissection. From a safety standpoint, there were understandable concerns regarding post-operative complications associated with segmentectomy due to its technical complexity. However, in the JACS 0802, the incidence of early post-operative complications were nearly identical between lobectomy and segmentectomy arms. Moreover, neither 30-day nor 90-day mortality was observed after lobectomy or segmentectomy in this trial. These findings clearly demonstrated that segmentectomy is a very safe procedure. So far, we have no randomized trial directly comparing segmentectomy with wedge resection. Therefore, we conducted a retrospective study using propensity score matching to compare these two procedures in patients with clinical stage 1A non-small cell lung cancer. The cumulative incidence of recurrence was significantly lower in the segmentectomy group. The 5-year cumulative incidence of recurrence was 30.2% for wedge resection and 6.6% for segmentectomy, with a hazard ratio of 0.48. These findings suggest that segmentectomy may provide superior oncologic control compared to wedge resection. Dr. Shiono was awarded the Brompton Prize for this study at ESTS meeting last year. The paper concluded that sublobal resection is inferior to lobectomy in hypermetabolic tumors, which were defined as having a primary tumor SV max of 3 or higher. When we're looking at the freedom from recurrence, the overall results of sublobal resection appear worse. However, when separating wedge resection from segmentectomy, a significant difference emerges. Segmentectomy achieved outcomes similar to lobectomy, while wedge resection did not. Next, I'd like to share pulmonary function outcomes after complex segmentectomy. When compared single segmentectomy, there was no significant difference in post-operative reduction of FVC, FEV1, and DLCO. However, when comparing complex segmentectomy to lobectomy, segmentectomy showed significantly better preservation of pulmonary function. Interestingly, there was no significant difference between complex segmentectomy and wedge resection in terms of post-operative pulmonary function. Based on the evidence and experience presented so far, I personally prefer segmentectomy rather than wedge resection when performing sublobal resection. Segmentectomy offers a more balanced benefit in terms of oncologic control, safety, and functional preservation. I believe that if we continue to master and refine all types of segmentectomy, the technical challenges will become more manageable and the procedure will become more broadly applicable. Finally, I'd like to introduce the JACS 1909 trial, also known as the ANSWER study. This is a randomized phase 3 trial comparing wedge resection with segmentectomy in patients with clinical stage 1A non-small cell lung cancer who are considered high risk for lobectomy. High-risk status is defined according to the IXOC Z4032 criteria or Charleston Comorbidity Index score of 3 or greater. The primary endpoint is overall survival. JACS 1909 aims to answer a critical question. When we perform sublobal resection in high-risk patients, should we choose wedge resection or segmentectomy? So in conclusions, for GGO-dominant tumors, both wedge resection and segmentectomy are appropriate if the surgical margin is sufficient. For solid-dominant tumors, anatomical segmentectomy is preferable over wedge resection. Wedge resection may be acceptable after NZL confirmation during surgery. Thank you for your attention.
Thank you, Dr. Tsani. Thank you, Dr. Tsani, for your great presentation. So now open for discussion from the audience. We accepted each question for each speaker. So anyone?
Hi, enjoyed your presentation. Question relates to surgical margin, and at what point do you upgrade the operation? You do a segmentectomy and you get a 1 millimeter margin, would you then proceed with a completion lobectomy, or are you happy with the 1 millimeter margin on frozen?
I prefer just reject the additional wedge over segment. So I really avoid the lobectomy.
So, I mean, really, it's a question for, is a 1 millimeter margin sufficient? Would you just kind of accept that, or would you try to extract additional margin, or if the decision is to do a lobectomy, would you then proceed with a lobectomy?
In such situation, a lobectomy is acceptable.
Okay, all right, thank you.
Okay, next.
Dr. Suzuki from Tokyo, Japan. Thank you for your extensive review. I want to ask you, I think you did not mention the disadvantage of segmentectomy. For example, local regional recurrence is twice compared to a lobectomy, especially for hypermetabolic tumor. So I want to ask you, which operative procedure do you perform when the hypermetabolic tumor is located segment 6, between segment 6 and segment 9, in the left side? Segment 6 and 9, just right between the both segments, the hypermetabolic tumor.
So if I can take the substrate margin, I preserve maybe S7 and S8 in this situation, but if that technically impossible, I'll do a lobectomy in that case.
I think for such kind of tumor, maintain enough surgical margin is really difficult. So we have to pay attention to keep a good margin.
I agree.
Okay, please.
Thank you. Dr. Enrique Guzman from Mexico. One question, is there a reason why are you, in your study, randomized study between segmentectomy and wedge, why are you including less than 3 centimeters in diameter? Because I think that would be a bias for segmentectomy and against wedge resection. Why would you include tumors larger than 2 centimeters?
The study included up to 3 centimeters in size.
So I think that 3 centimeters is a large tumor for a wedge resection. So it's going to be a bias for the segmentectomy and against wedge resection. Is there a reason why and not include just tumors 2 centimeters?
Right, but in this situation, the study subset is a high-risk patient for lobectomy. So if we can reject with a wedge resection with ample margins, that's the candidate for this trial. But it's impossible. We will not randomize to this patient. Yeah.
Okay. Anyone? Okay, Dr. Tsutani, one question from me. Okay, you introduced the ACOSOG trial and a series of JACOB trials. So you can accept the ACOSOG trial, right?
CLGB, so including wedge resection.
Yeah. CLGB, yeah, sorry.
That's important point. In the trial, prior to randomization and interoperative N0 status is required to confirmation. So in that situation, wedge resection is acceptable, maybe acceptable.
Maybe acceptable. Okay. Okay. Thank you for answering.
Hi. Question?
Oh,
Can I?
last question.
Yeah, last
please.
question.
Short question, please.
Yeah, thank you. Obada, UK. My question about what's the indication for completion lobectomy after you go out? Yeah. The indication for completion lobectomy. Post-surgery, post-segmentectomy or sublobar resection.
Yeah, I do not recommend completion lobectomy in any case.
In any case? Okay.
So if we found the positive lymph nodes, we we do not do a completion lobectomy, but we just offer our adjuvant therapy.
Okay.
Also, but surgical margin is positive. I consider the completion lobectomy.
Okay. Post-op, if, yeah.
Yeah.
Okay, thank
Okay,
you.
we must go next. Thank you, Tsutani.
Thank you.
The second speaker is Dr. Nasser Al-Toki, a professor of cardiothoracic surgery, Weill Cornell Medicine, New York, and principal investigator of the CLGB trial. So we are deeply honored by his presence here today, given his exceptionally busy schedule. Please start, Professor Al-Toki.
That's not mine. These are not the slides. I'm happy to talk about that, but that's not. This is the third talk. Can you go back to the second talk, please?
Please change the slide.
Yeah, there you go. That's more like it. Okay, well, thank you very much. This was a great talk, and I feel that I'm in the hot seat after this great presentation. So I just want to know how much in the hot seat am I? I want to show of hands on this one here. 1.3 centimeter tumor, node negative by frozen section, and in the apical area of the left upper lobe. Show of hands, who would do a segment? Oh, it's not too bad. We're in good shape here. Who would do a wedge? Yeah, so I think it's even. I didn't count, obviously. So we all do what we've been raised to do. Our teachers pass it on one to the other, and it becomes seared in the consciousness of all thoracic surgeons. And the study that was a transformative study in thoracic surgery was done by Bob Ginsberg and the lung cancer study group, and basically put the dagger in wedge resection as a primary modality of treatment. And I think some of you in this, many of you in this room know the trial well. Some of you may not know the intricate details. So I want to just go through them to make sure we understand exactly what they did. So first of all, suspected or confirmed T1N0, 3 centimeters in size. That's really important. The questioner from Mexico posed a very good question. And the staging was done by history and physical exam, some laboratory tests, and only if you had any symptoms of metastatic spread did you get a bone scan or a CAT scan or an ultrasound of the liver. So that's, let's just say we don't do that anymore. Then they went to the operating room, they did a bunch of frozen section of the lymph nodes, and then get this, and you can check the primary paper if you like. The surgeon confirmed the size of the tumor intraoperatively, and I don't really understand how the surgeon did that, but they did. And then the patient was randomized to a lobectomy or a sublobar resection segment of wedge, and you can see here 122 patients were randomized to segmental resections, and only 40 wedge resections. So the dagger was thrust in the heart of wedge resections forever based on these 40 patients. I would think that that probably is not the best demonstration. And here is the survival that was presented, published in the Annals of Thoracic Surgery. Mind you, the recruitment happened from 1981 to 1988. Paper was published in 1995. And well, maybe there is a difference. If there is one, I don't see it. The p-value was 0.08. There was certainly an increase in the reported incidence of overall death rate and death from cancer in the sublobar resection group. Lobectomy was declared as the standard of care, and we all grew up with that gold standard being dominant. So when people say to me that, anatomical segmentectomy is a better oncological operation because it takes all the lymph nodes and all that. That's exactly what we said about lobectomy for over 30 years. So, we should be guided by the data, not by what people say. Now, they did publish in a subsequent letter to the editor the incidence of recurrence based on the type of resection, and you can see the lung cancer recurrence per person per year for lobectomy was 0.02, 0.04 for segment, and 0.08 for wedge. So it was double that of lobectomy by segmentectomy and almost 4 times higher than lobectomy by wedge resection. But if you read the paper, this is what the authors say in the results section. Doubling of the recurrence rate associated with the limited resection arm appears to apply regardless of whether the intended resection was a wedge or a segment. So it is possible that we actually skipped some of the important caveats that were suggested by the authors. And since the 1980s, there's clearly a rationale for sublobar resection, including wedge resection. We're seeing smaller tumors. People are living longer and may not be able to tolerate lobectomy as a definitive surgical procedure. And of course, most importantly, there are emerging competing methods of treatment, including SBRT, among others. And people have been interested again in rehashing this, but most of that was based on population-based studies and case series and expert opinion. And I don't care how much propensity matching you do, there is always going to be a bias in these. And the only way to really answer the question is a randomized trial. So we looked at that, as you know, in 2005, 2 centimeters or less, peripherally located, and we tried to select for a highly probable node-negative population by doing the frozen sections of the lymph nodes during before randomization. Patients were then randomized to lobectomy, and we decided that we will do both because that's what was out there. People were doing a lot of wedges, and we wanted to study wedges. And then the question was, well, are lobectomies and are segmentectomies and wedge similar? Dr. Tsutani already went over the primary results, so I will not visit that. But we looked at the question of segments versus wedges, and after accounting for all the conversions that happened, 362 had a lobectomy, 131 segments, and 204 wedge resections. You can see that even in premier institutions of thoracic surgery in Canada, Australia, and the United States, people did more wedges. Almost 2/3 of the cases were wedge resection. So we compared all 3 of them. This has been already presented. I will try and go through them so that I can stay within my time allotment. This is the 3 groups. They were similar for median tumor size, for the stratification factor, so the majority were between 1 and 1.5. For smoking status, pathological characteristics, paradoxically, patients who had wedge resection were more likely to have a complete lymph node dissection than the other 2. And the upstaging to N-positive disease was progressively higher as you went from wedge to segment to lobe, but that was statistically significant. We looked at disease-free survival. There was no difference between all 3 types of resection, wedge, segment, or lobe. Overall survival was essentially the same, 79% after lobectomy, 81% after segmentectomy, 78% after lobe, 79% after wedge resection. Recurrence-free survival was also similar, almost 69% versus 68% for wedge versus segment. And then we looked at the cumulative incidence of lung cancer-related deaths and competing causes of death. This requires a bit of an explanation. The solid lines are the lung cancer-related death. The green is the segment. The blue is the wedge. There were slightly more deaths from lung cancer in the segmentectomy group versus the wedge resection group. And the dashed lines are the competing causes of death, which are essentially similar between the 2 groups. So the overall recurrence rates were consistent with the overall trial results, 30%. There were slightly more local regional recurrences in the wedges, 14 versus 12%. This was not statistically significant. You might argue that in a larger sample size, it might be. Nonetheless, the absolute difference remains small. We looked at recurrence-free survival based on the extent of lymph node dissection, whether systematic sampling was done or complete lymph node dissection. We presented this data at the AATS meeting less than a month ago, and you can see wedge versus segment in the node dissection group had identical disease-free, recurrence-free survival, and wedge versus segment with only sampling had identical recurrence-free survival. What are the predictors of recurrence-free survival based on multivariable analysis? So lymph node dissection was not a predictor of recurrence-free survival. The extent of this resection was not a predictor. And what was a predictor, however, was interestingly patients who are current active smokers. They were at higher risk of recurrence. So that's interesting, almost a 50% higher probability of recurrence. And more importantly, the driver here appears to be tumor size. So patients who had a tumor size between 1.5 to 2 had a 33% higher probability of worse recurrence-free survival in general. So we then asked the question is, okay, so how are we going to provide some quality metrics to the sublobar resection group? We asked surgeons to obtain, it's not a requirement, it was just a recommendation. Obtain a 2 centimeter margin. If you can't get a 2 centimeter margin, get a margin equivalent to the tumor size. Measure the margin, please, by the surgeon in the OR, and get a frozen section if in doubt, and a positive margin will require an additional wedge resection, an anatomical segmentectomy, or a lobectomy. Please do not leave the operating room with a positive margin. Okay, so we looked at the margin. We asked people to freeze the margin. We were not sure how many were complied, but amazingly, 76% complied with that, 136 of the wedges and 76% of the segmentectomies. As you can see, the margin length in the segmentectomy, the surgical margin was longer in the segmentectomy group than in the wedge resection group. That's predictable. That was statistically significant. And the ratio between the surgical margin and the clinical tumor size, not the pathological tumor size, was borderline significantly higher in the segmentectomy group. We looked at the intraoperative margin assessment by frozen section. So again, a lot of the patients had an assessment by frozen section of the margin. And you can see that with the criteria that we established, 5% of the patients in the wedge group had a positive margin. These were 10 patients. Only 2 were found on permanent section. The remainder, the other 8 patients, were all remedied by either an additional wedge or a segment or a lobe. And 1.5% of the segmentectomies had a positive margin. We asked the question about what is the association between the surgical margin distance with local regional recurrence and survival. So we had 208 of 342 patients who had known surgical margin data, 135 of the wedges, 73 of the segments. And this shows you the overall between wedges and segments, 14% experienced a local regional recurrence. The surgical margin distance between patients who did and did not have a local regional recurrence, there was no difference overall between in the surgical margin distance. In the wedge group, there was no difference between those who did and did not have recurrence in the surgical margin distance. And in the segment, there was no difference in the surgical margin distance between the groups. Margin to tumor size ratio was also similar between patients with and without local regional recurrence. We looked at the local regional recurrence-free survival between segments and wedges. So the freedom from local regional recurrence was 84% after segmentectomy and 82.7% after wedge resection. So what are the predictors then of local regional free survival? It is not whether you do a wedge or a segment, and you can see that the hazard ratio is 1.1. But tumor size was a strong predictor of local regional recurrence. Again, tumors that were more than 1.5 centimeters were more likely to have local regional freedom recurrence, regardless of whether you did a wedge or a segment. And then the margin to tumor size ratio, and you can see how it progressively goes up with the highest probability of local regional recurrence in patients who had a margin to tumor size ratio of less than 1. So wedge resection, in conclusion, is an acceptable modality based on these data. And I just want to preface all that by saying the trial, as you all know, was not asking the question which is better. Patients were not randomized for that purpose. So this is a post hoc analysis, and you can take it for what it's worth. It's an acceptable modality of sublobar resection in carefully selected patients who are, this is an important point, enriched for node-negative disease. Remember that in JCOG, patients had frozen section of the lymph nodes only if the surgeon was suspicious of the lymph nodes. Here, in the CLGB trial, patients were not randomized unless the node-negative disease was confirmed in at least 3 locations. In this cohort of patients, which is the enriched population, wedge resection and segmental resection are associated with similar rates of local, regional, and distant recurrence and have comparable survival endpoints, regardless of what endpoint you might use. This patient, the wrong message was sometimes taken that we should not do any more nodal dissection. Therapeutic wedge resection must be accompanied by an adequate, at least, lymph node sampling or complete lymph node dissection. As far as the margin is concerned, a resection margin of 2 centimeters or one that is equivalent to the tumor size is preferred whenever possible. Someone asked about a 1 millimeter margin. Sometimes you can't get more than a 1 millimeter margin. And my personal opinion is you need a negative margin, because the data on the relationship between surgical margin distance and recurrence seems not 100% persuasive. There are patients who recurred with a 2 centimeter margins, and there are patients that did not recur with a 1 millimeter margin. So we must not forget that there is biology behind all this, and surgery does not cure necessarily biology. So you need a negative margin. If you think you can add to the margin by an additional wedge resection, fine. If you want to do a segment, fine. But I would agree with Dr. Tsutani, the alternative should not be a lobar resection. And then a frozen section examination of the closest resection margin to the tumor, in my opinion, is mandatory. You get a lot of pushback about doing a frozen section. Oh, it takes too long. We can't wait for it. Well, I get that. We all don't like waiting for the pathologist to call us back, but I think that that's really important. And I'll just close with that and take questions now.
Thank you. Thank you for your presentation. Okay, open for discussion, please.
Yeah, Dr. Altorki, just wondering if you had a chance to look at PET data and whether lesions were solid versus ground glass. If you had a pure solid lesion, is there a difference between segment and wedge? And if you didn't look at that, what your personal feelings are for a pure solid lesion?
Yeah, so I get that question a lot, Chris. I remind you, this study started in 2005. We didn't know very much about ground glass then. So the requirement was the solid component had to measure 2 centimeters. Now, I know that there are data out there about having a mixed morphologic appearance on the CT scan favors a good prognosis. But for the most part, I can tell you that most of the cases in this trial were solid lesions. I had a slide that I took out earlier because of the time constraints. It's your trial on the sublobar resection for plus brachytherapy. And it was one of the trials that sort of was important, showing that there's no difference in survival between wedges and segment, even in that cohort. These were solid for sure.
Next, please.
Thank you.
Yes.
Nasser, great presentation. Paulo Ugaldi for Boston. I have 3 questions, but they're all really very quick.
Easy?
Easy and quick. Number 1, in your practice today, what lymph nodes you send for frozen when you're doing either a wedge or a segment? What are you sending for frozen? Be true. Truthful.
Are you waiting for the answer, or are you going to give me the other 2?
No, go ahead.
Oh, okay. So, I struggle with that, okay? Here's my view on this, right? Every patient who has this stage of disease goes to the operating room with a CT PET and a CAT scan. And there are good randomized data, by the way. You can all look it up, and I can tell you what the paper is. that shows that for CT PET scans that are negative in the mediastinum, the probability of a false negative are anywhere between 3 and 5%. So no more really than the upstaging. So I don't necessarily send them for frozen section. I do send the margin for frozen section, and I wait for that.
All right. More like the Japanese trial. Second question. When you send your specimen to frozen, again...
Can I just go back to that question for a second? I think people misrepresent this frozen section of the lymph node. We wanted to make sure that we're not hurting patients.
Yeah.
And therefore, patients should not be randomized unless we actually know that we're enriching. So however you want to enrich for that node-negative group, you can do it.
When your specimen is in the frozen section, how does your pathology measures the margin? From the lesion to the staple line, they take the staple line and they measure it. They measure it in the slide. How do they measure the margin?
Very, very good and murky answer. Okay, we need to work with them. Almost all of them have to actually resect the staple line and keep it. Okay. For a while there, we did what our colleagues in Japan had suggested, which is the margin spot cytology. So you sort of like get the slide and you hit it several times with the staple in place, and then you get a cytologist in the room. Now they refuse to come to the room. So we just need to talk to the pathologist, and sometimes I myself go upstairs as it were, to look at the pathology with them and make sure that we're all agreeing on the margin.
I think I'm going to let the others...
No? One question. Sorry, please.
Yeah, I'm Sato from University of Tsukuba. Thank you very much for your presentation. I have just one question.
Oh, there you are.
Yeah. You mentioned after wedge resection, if the margin is not enough or positive, you're going to consider segmentectomy or lobectomy. But after large wedge resection, lung deforms a lot. It's kind of difficult to perform anatomical segmentectomy. I think surgical design is more important. So how do you
surgical what?
Surgical design. If you perform wedge or segmentectomy, I think it's better to decide before surgery. How do you think about that?
Okay, so the question is, if I can reframe the question, what do I do? And I'll tell you what I do. For patients who have a tumor less than 1.5 centimeters, less than 1 centimeter, I think a wedge is perfectly fine. I think between 1.1 and 1.5 centimeter, I have a lot of equipoise between wedges and segments, and will base my decision on other factors, patient-related factors, patient's age, whatever. And I think if tumors larger than 1.5 centimeter, my personal preference is to do an anatomical segmentectomy. So I don't usually find myself in a situation in which I have a large wedge resection. I think if you need a large wedge resection, then you're probably not looking at a much larger tumor than you should.
Not only the size,
Sato,
but
Sato, sorry.
location.
Stop it. Sorry. Quick one, last question.
Yes, Laura Molins from Barcelona, Spain. Congrats, Nasser, for your work in this topic. Which is the role of the STAS in the recurrence and overall survival? I mean, we cannot know the STAS in intraoperatory. But what about post-op? Should change if you find the STAS in the wedge resection?
Quick answer, please.
Yes, very quickly. Well, the Japanese colleagues are presenting the results of STAS, I think, in the next ISLC meeting in Barcelona, so you will be there. And I think they are. I personally, we're still looking into that in the CLGB trial. The Cornell cohort of patients that we randomized in the trial, I have not seen one of them that had STAS in it.
Good.
Okay.
Thanks.
Okay, thank you for our talk.
Thank you very much, and I would like to ask Professor René Petersen. Please, René.
Thank you very much. So based on these two talks, I'm just going to address now quality standards for performing segmentectomy. These are my disclosures. We know very well now we have three very well-designed randomized controlled trials proving equity and one of them superiority for segmentectomy. The JACS showed superiority, but recently at the AHES, the 10-year survival data were presented, and the superiority for segmentectomy is no longer significant. There's still a 4% difference between the two groups, but it's no longer significant. So looking into the details of the JACS trial, there's definitely an issue with the surgical margin. There's a twice as high local recurrence rate in the segmentectomy group. 11 of those were at the surgical margin and 21 were at the ipsilateral lymph node side. We then have the CLGB trial, and when we look into the recurrence rate in the CLGB trial, it was 13% in the sublobar group, as we just heard about. It was not significant, but it was numerically higher than in the lobar group. So, do we have an issue when we perform segmentectomy? This is a very nice paper recently published in the Journal of Thoracic and Cardiovascular Surgery by the group of the women in Brigham in Boston. They were looking at the quality of segmentectomy. So, and addressing the four elements, the pulmonary segment, the artery, the vein, and the bronchus. And looking into this, the data in this retrospective study, actually 20% of the so-called segmentectomies did not have a bronchus divided. So they named them non-anatomical segmentectomies, or basically wedge resections, but let's just keep with that. And as you can see, there is a significant difference in margin, 1.5 centimeter versus 1 centimeter, and there's a significant difference in the number of lymph nodes, 6 versus 2. And based on this study, they concluded that we need to establish a professional standard for performing segmentectomy. So we were a small group of within the ESTS led by Alessandro Brunelli, who published this expert consensus paper. We asked experts across Europe a couple of questions on how to perform a segmentectomy. And the consensus-based recommendations were that a segmentectomy should be defined as a long resection that include dissection and division of at least the corresponding segmental arteries and bronchi. Veins can be optional, especially in complex segmentectomies. They can be divided along the intersegmental plane. And segmentectomy should be classified into single and multiple segmentectomies. And further, a systematic or lobe-specific hilar and mediastinal lymph node dissection according to the ESTS guidelines were recommended. And again, based on the question asked earlier, a frozen section on the segmental nodes, and these are the segmental nodes at the foot of the segmental bronchus, should be performed in all cases, and in case of a positive node, a completion lobectomy should be performed. These are, remember, the opinions of the expert, and it's with the exception of pure GGO lesions and patients unfit for lobectomy. And when we look at the intersegmental plane, preferably you should use infrared fluorescence cameras with the ICG injection. The margin, 1 centimeter or at least a margin tumor ratio of 1. And in case of a positive margin, adjacent parenchyma should be resected up to a completion lobectomy. So we all know segmentectomies are a complex operation. When we started with VATS lobectomy many years ago, we said the learning curve was 50 cases. This is a very nice paper from Japan analyzing the learning curve of segmentectomy using the QSUM analysis. And as you can see, it's 84 cases in this study. I think it reflects very well that there is an increased complexity in performing segmentectomy, and there's definitely a learning curve. And especially the complex segmentectomy may be difficult, and are they actually safe? This was addressed in this study by the group of Okada, comparing simple versus complex segmentectomies, and the definition is everything more than one stapler line is a complex segmentectomy. And looking at these data, there were no difference in complication rates. However, it took, on average, 40 minutes more to do the complex segmentectomies. And we know also from the result of the JACS trial that there were more air leaks in the segmentectomy group as the only complication that was different between the two cohorts, and this was attributed to complex segmentectomies. So what is the surgical margin? What's the ideal surgical margin? Well, the NCCN guidelines recommend 2 centimeters, as we just heard from Nassal Torki. When we look at the European EACTS, ESTS guidelines, it's 1 centimeter or tumor ratio of 1. And if we ask the AHES from their recent published consensus guideline, there is no clear standard for the surgical margin. We address this in our cohort, and these are our patients. 16 millimeter was the median tumor size, and the median resection margin was 20 millimeters. And these are the different segmentectomies. And analyzing the data, we could see that the optimal margin has to be more than 2 centimeters. So if you have a margin that is 1 centimeter, the odds ratio is 3 for local recurrence. So there was a significant higher local recurrence rate the smaller the margin, and especially the closer you get to the tumor. So this is, I think, a clear signal that when we do segmentectomies, we need broad margins. And I think this goes also for wedges, but we could not interpret this from this study. But it affected overall survival, local recurrence-free survival, and lung cancer-specific survival were all affected, again, on the whether the margin size was below or above 20 millimeters. So how can we navigate according to the margin size? Well, we all know today that nobody's, at least very few people are going anywhere without putting on the GPS. And when you ask this panel of experts, 96% of them recommend a preoperative 3D reconstruction. The group from Paris by Dominique Gauzot and Agathe Seguin-Guivillet have published a couple of papers on this, and stating that there are so many anatomical variations on the segmented level that's really something to be aware of, and you need a 3D reconstruction to be aware of this. This is just one example of how what you think is the lingual artery is actually including the artery for segment 3. And this leads to unplanned procedures. There can be unplanned conversions, and it can be unplanned additional resections. So this is really crucial. There are many 3D reconstruction tools on the market. We use this one, and basically because it can be integrated into our PACS system, which means that every morning before we perform segmentectomy, we are presented by the radiologist with the 3D reconstruction, and we put the 2 centimeter margin around the tumor so you can see exactly up front which segments are you going to resect. And we all know, for instance, that there are more local recurrences in segment 6. And when you make these 3D reconstruction, realize that a lot of the tumors that you thought were in segment 6 is actually in the border between segment 6 and 10, and it's not sufficient just to do an additional wedge in 10. You have to do anatomical resection of 6 and 10 to get the 2 centimeter margin. But all of this we are prepared for ahead of surgery, and this is crucial. And again, for the intersegmental planes, there are many methods, as you can see from this paper, also from Gauzot's group. But the ICG is becoming increasingly popular because you do not need to inflate the lung, and when you inject ICG, this is only 5 milligrams of ICG, and you can see clearly the margins of a segment 3 resection. And then you can mark it because you will have to turn on the fluorescence camera. And this is the segment 7 and 8, and you can see how nicely you see the intersegmental planes. but if I let this video play a little bit, you will see that you have to be fast because there will be some diffusion into the segment. So if you're too slow to make your margins, your marks, it may be more difficult. As you can see now, the dye is diffusing into the segment. So how about the lymph nodes? So Nasal Toki presented his data from the CLGB showing at the AHS and also today, showing that there is no difference between systematic lymph node dissection or lymph node sampling in the CLGB trial. We looked at this in a recent paper in our cohort, and we could see, first of all, that there were very little upstaging in this group of patients, and looking at the median number of 9 lymph nodes of the group below and above, we could see there were no difference in survival between those two groups. So we couldn't really prove that the number of lymph nodes was affecting these very early stage lung cancers. Then lastly, I will address STAS, as was one of the questions previously. We looked at our cohort based on all the data from MSK on STAS, and we compared lobectomies to segmentectomies, and we could see a clear survival difference between the segmentectomy and the lobectomy in the STAS positive group. So definitely it looks like STAS positive patients do better with the lobectomy. However, our challenge now is to see this on frozen section or to evaluate this before surgery. This will definitely require further research. So just to sum up, I think there's strong evidence for segmentectomy. It's becoming standard of care across the world in less than 2 centimeters. Quality standards for performing segmentectomy is crucial. It is extremely important that we perform a good quality of segmentectomy. And a margin is not just a matter of stapling a bit more. To get a sufficient margin, especially in the more central tumors, you need to do more hilar dissection, and the hilar dissection is more difficult and maybe can be dangerous if you injure the neighboring vein, and then you have to do an additional segmental resection. Division of segmental artery and bronchus are mandatory, and veins can be divided in the intersegmental plane. And 3D reconstruction ensure knowledge of anatomical variations, knowledge of margins, knowledge of segments to be removed. And the use of ICG ensures a safe and easy identification of intersegmental planes. And margins should be, we believe, so far only from retrospective studies, we should aim for a 2 centimeter margin. Systematic lymph node dissection or lobe-specific lymph node dissection for segmentectomy, that's the question. That's what we're going to address in future trials, and I know that JACOG is looking into this. And what about STAS? We need better tools to predict STAS pre-surgery. And then finally, I would just remind you all that we will repeat this wonderful meeting next year in Athens in June. And thank you very much for your attention.
Yes, please.
Thank you, Rennie. Nice presentation. I'm Dr. Shiono from Japan. So you have shown that the relationship with STAS and disease-free survival. So you showed that STAS positive lung cancer has a higher recurrence rate in segmentectomy. So I would like to ask you about what is a recurrence pattern in STAS positive lung cancer? I think that the STAS positive lung cancer tends to be higher rate of surgical margin recurrence. How about your data?
Yeah, I have to say that there's a small number of STAS positive patients, so we can't, the data doesn't really allow for a granular interpretation. But we do see a trend that the STAS positive patients have more aggressive histology, such as micropapillary pattern or a very high SUV rate. So the question is whether we will be able to predict which patients have STAS and therefore schedule for lobectomy in these patients.
Thank you.
Thank you. Next, please.
Okay, thank you, René. I'm Mark from Istanbul. So just to be clear before going home, if you have a patient, you operated segment or wedge, then you have a STAS positivity on pathology, what would you do? How you go further? You go with the complete lobectomy or you go with the adjuvant chemo?
Yeah, that's a very good question. And for now, we don't really know the answer, do we? But based on this trial, we can see that if we do not do a completion lobectomy, there will be a higher risk of local recurrence and poor survival, and therefore we have to address this to the patient. That's what we do in the outpatient clinic, but most people decline the completion lobectomy, I have to say.
Yeah, we just start to explain to patients that we are doing something smaller, but then we need to explain about the STAS. So it's going to be a little bit complicated for the patients.
Oh, could you please repeat the sound?
No, we just talk about the segments and inferior resections, and we're trying to
Sorry, this is the last question.
Pardon?
This is the last question. Sorry, we don't have time.
No, okay, no question. Okay, thank you.
Okay, then the lady. Sorry, the lady wanted to. You are the last one.
Paula, you still have the chance.
Yes.
Renee, quick question. So you presented our data on the type of segmentectomy performed, right? And then we updated that data and we looked at the rate of recurrence, comparing patients that had complete segmentectomy where all elements were dissected versus the non-complete. And we did show in our data that our patients had a higher recurrence rate of lung cancer when you perform a incomplete or non-complete, call it however you want, segmentectomy. We were not able to show if this was related to the quality of the lymph node dissection, to the margins, etc. But there seems to be a relation. So my question is, in your practice, when you do a segmentectomy, do you aim to dissect the three elements, vein, artery, and bronchus?
Always. I think if you do not divide the artery and the bronchus, it's not a segment. It's a wedge. And the veins in complex segmentectomies you can do in the intersegmental plane, but in most bi- and tri-segmentectomies you should remove the vein as well. I think the bronchus is really the limiting part in getting you sufficient resection margin, especially in more central tumors. And that's where that's the crucial part, is to get the bronchus divided and also to extend your dissection into the higher structures so that you get the segment lifted away from the remaining segment. In that way, you will get a better margin. And that's the technically difficult part. I think that's where the learning curve is for segmentectomy. But I do think from the data we have for now, that is really crucial.
Thank you.
Okay, thank you very much. And thank you very much for the Japanese colleagues to join us. Thank you.